Everybody see that okay?
Working perfectly there. Yeah.
Great, great. So this is a real honor for me. Dr. Jane was one of my closest mentors and inspirations, and so it's an honor to be able to give this lecture in his name. Um, I, uh, I wanted to just start off and really, this lecture is about what I learned as a resident and in some ways how I've applied it throughout my career. So I am a UVA graduate. Dr. Asquian and me were co-residents and got to work with Dr. Monteith and others at the University of Virginia. But my personal introduction to UVA, where I trained in residency, I grew up in Canada. I went to college, med school, etc. And my mentor in med school told me that I needed to go to Charlottesville to see the program there because he thought it was the best training program in the world. So I went to UVA as a young medical student and really had an unbelievable experience that changed the trajectory really of my life. But I rotated at UVA, and what I found was a few things which were unique. Unique compared to some of the other programs I had exposure to. There was a tremendous sense of camaraderie. People worked exceptionally hard, but also had a lot of fun together. And it was a close-knit unit. And really, it was kind of a family environment. So this is a picture of, a famous thing that happens at UVA is the Christmas in June party, which is to celebrate the graduating residents as well as staff and all team members, really. And people got together. It's an informal but a great time around the pool at the Jane's house. And that was always a highlight of the year. Another thing that I immediately was exposed to, and I know that this is a concept that's in place at SSF, is that there's a book by, or a short essay by Albert Hubbard, A Message to Garcia, and really this was a theme in UVA. But a couple of highlights, basically A Message to Garcia is about someone, Colonel Rowan, who really gets the job done without asking questions, without any excuses, without a lot of direction, but gets things done. A couple of highlights from this essay that I really like that have stuck with me over the years. It is not book learning young men need, nor instruction about this or that, but a stiffening of the vertebra, which will cause them to be loyal to a trust, to act promptly, concentrate their energies, do the thing, carry a message to Garcia. And then the other thing is my heart goes out to the man who does his work when the boss is away, as well as when he is home. And that's something that I try to pass on to residents, and it really has stuck with me since my training. Another thing that was really important that I think has influenced me as well as teaching conference, the importance of teaching conference. And this is something that all residents had to attend, no excuses. And it was a time, Dr. Jane was present for every conference. Just checking the chat box. And it was a very special time, and it was every Wednesday and Saturday morning during my residency. But we, in our program, conference is absolutely a very important part of our education. The other thing that stuck with me was these brain slices, and some cringe, maybe Rod cringes a little bit when we see this, but brain slices were basically, it's an atlas where there's numbers pointing to pictures, and you can't always tell what the numbers are pointing to intuitively. So it becomes a rote memorization exercise. And we would get quizzed every Saturday morning. You get quizzed until all the brain slices are done, and what would be asked of people would be random. So you really had to put in the time. And I remember when I was a resident that the first time I was doing this, I was on call and I didn't have time to prepare like I should have. And my brother was in town, and my brother was a visiting medical student at the time. And my brother got it perfect on the brain slices, and I missed a couple, and I missed a couple because I didn't prepare. And from that moment on, I knew I had to put in the time in a disciplined fashion. Um, and from that time on, I don't think I missed one after that, but it was a very humbling lesson that I learned that I had to put in the time. And this applies to everything in life, I think, when I'm reviewing for journals, etc., and there's a high volume, you just have to have the discipline to work through it in an optimal fashion. The other thing I learned as a resident is that, I thought neurosurgery was 24/7, 365, and that's what you think as a resident. But I think what also I was exposed to was that all of my mentors had interests outside of neurosurgery. So whether it was wine, cooking, sports, reading, gardening, it was very multifaceted, I think, and this has had an influence on me as well. Because to be at your best, I think that you have to have some balance. And we had wonderful examples in our mentors of how to do that successfully. The other thing that I learned is that you should treat everyone with the same amount of respect, whether it's the president of the world's largest company or a custodian or whoever it is. You treat everybody with respect. And this just reminds me that one of our custodians at our building where our office is in doesn't know me from, doesn't know my surgical skills or lack thereof, but knows that, we have conversations about his family and outside interests, etc. And so when his wife had this aneurysm discovered, he didn't know, he knew me, and he felt very comfortable, although he had no knowledge of my skills. And it's just a reminder that you treat everyone with respect. And Dr. Jane really exemplified that and something he passed on to all residents. I think another thing that was very apparent is that the importance of family. And so we worked 7 days a week during residency, and Dr. Jane would hold something at his house on Sundays called Sunday School. And it was where you discussed a journal or sometimes a chapter in a textbook, but you would meet for exactly 1 hour and together, usually the residents who are in the lab and maybe some of the senior residents. But my daughter here on the right side would come with me to Sunday school, and he would go in the kitchen with Mrs. Jane, and they'd hang out while we did our journal club, and she absolutely loved it. And Dr. Jane, of course, opened his home up to everyone, and really viewed people as an extension of his family and welcomed them. And so time flies, but my daughter here, some years later, it was really emphasized the importance of family and taking time to spend with them. But when you're busy, integrate your family into your workflow or work life. And that's been really important. I think another thing is that neurosurgery really requires a commitment. And really any surgical specialty or any specialty or vocation. And this is a quote that Dave Saby had sent me, but it says that until one is committed, there is hesitancy, the chance to draw back, always ineffectiveness. Concerning all acts of initiative and creation, there is one elementary truth, the ignorance of which kills countless ideas and splendid plans, that the moment one commits oneself, then providence moves too. All sorts of things occur to help one that would never have otherwise occurred. A whole stream of events issues from the decision rising in one's favor, all manner of unforeseen incidents and meetings and material assistance, which no man could have dreamed would have come his way. Whatever you can do or dream you can do, begin it. Boldness has genius, power, and magic in it. Begin it now. From Von Goethe. And I think that this applies something that, the idea of just going out and getting things done, I think has applied well in my life. I think the other things I learned as a resident, we were given quite a bit of autonomy, but I had learned the importance of practicing microsurgical skills in the lab, and SSF is such a great resource for that now. But back in when I was training, I did a lot of surgery on rodents, for instance, which was part of our experiments, and that was indispensable. And then the other thing that was emphasized is to read a little bit every day, and I still do this to this day, even if it's a few paragraphs or pages. Another thing that was passed on during residency, and really from Neil Cassell, but every time I talked to him, he asked me, what have I done recently that is new? And another takeaway was having diverse mentors is a true advantage. And I think that as residents, we see things that we really think are awesome and things that we think that are not as good. And we can learn from both those areas, and we can choose what we take into our practice when we're done. Dr. Jain also used to say, the devil finds work for idle hands. And I think that still applies. He wanted people to be busy, either clinically or doing research or reading, improving themselves. And we try to pass on as well. I think in terms of clinical care, a few important concepts are that the patient is really the center of everything we do, and we treat patients, not images. And another thing I learned during residency, and I emphasize this to all our residents, is one night I was busy on call in the emergency room, and some outside neurosurgeon called me, and I was very rude to him. There was a patient with a head injury, and the patient was GCS3, and I asked him if he put in an ICP monitor, and I said, it sounds like the patient is unstable. Why do you want to send it? And I was questioning him, which as a junior resident was absolutely a stupid thing to do. And I had to apologize profusely and try to call him back after he hung up on me to because I knew I did the wrong thing. But I learned that the answer is always yes. You just take patience, and that's something that I try to pass on, that you want to be a resource for other people, especially when they have a situation that's difficult. And the other thing that I saw during residency is really this dedication to a life in neurosurgery, where we had attendings as role models who rounded twice every day. Of course, we had weekend activities, and but really it was, a commitment to excellence in neurosurgery, and that was really passed on. The other thing that we sometimes forget is when we have a patient that we're operating on, we've made a decision to do surgery. What we do during the surgery can change their life forever, either positively and unfortunately sometimes negatively. And it's critical to focus during surgery, knowing that we're given an ultimate responsibility and have earned the trust of our patient and family. Residents may have a ton of things going on, but at that moment, when we're focusing on treating the patient, we have to devote our entire attention to that because of the potential impact. I think that now, more than ever, the patient should be at the center of what we do. And I think that, the patient is not outside our business. They are our business, and the patient is a person, not a statistic. And we can't forget that. And now more than ever, it's both the experience of the patient and the family, both before and after surgery. So it really doesn't matter, everything may have done perfectly. However, in post-op care, if the patient and family are having some communication breakdowns, or they've been given the runaround for whatever reason, that can really ruin the experience. And from start to finish, I think it's important that we have to provide the best possible care and service. Another interesting thing is Dr. Jain had a very flexible mind. And when I told him that I thought I wanted to do endovascular, um, he started laughing at me, and he said, and I remember this, Aaron, you don't want to be twiddling your thumbs manipulating a catheter or wire for the rest of your career when you should focus on skull base and clipping aneurysms. And I thought that was funny at the time, but he said in retrospect, after I'd finished my training, that, this was absolutely the right thing to do, and he was wrong. And so he always spoke what was on his mind, but he was also very flexible in his thinking. And another important thing that he emphasized was the multidisciplinary nature of what we do in certain areas. Like, he was a master in craniofacial surgery. And so this is actually a slide from one of his talks. And he talked about how different specialties are so important, in addition to neurosurgery and dealing with, for example, craniofacial with plastics, ophthalmology, and even orthopedics in some regards, if it's cranial, cervical, et cetera. But I think this applies in other areas. So I think that neurosurgery taking a leadership role in endovascular was really important, with Nick Hopkins and Robert Rosenwasser among the early people pioneering the field. Obviously, radiology started this, and some of it was derived, of course, from cardiology. But neurosurgery having a seat at the table and continuing this on, I think, was really important as part of a multidisciplinary team now, of course, with neurosurgery, radiology, neurology, et cetera. And this was also important in spine surgery. Neurosurgery working with orthopedic surgery was, I think, critical in moving the specialty forward. When I was a resident starting, neurosurgery did decompression and orthopedics instrumentation, and that's the way it was. But I think the next frontier will probably be neurocritical care. I think that neurosurgery has a major role as part of a multidisciplinary team in neurocritical care. And I think that we shouldn't forget the importance of this. And I think neurosurgery having a seat at the table is important there. I think the other thing that Dr. Jain emphasized really in residency, which has stuck with me, is that flexibility in clinical care. So this is obviously a patient with an MCA aneurysm, and most MCA aneurysms, at least at the time that this was treated, would be treated with microsurgery. Broad neck aneurysm, one of the branches, is involved, but Dr. Jain would say prohibit sharply the rehearsed response, meaning that just because it's an MCA aneurysm doesn't mean that all of them will be clipped. This patient had neurogenic stunned myocardium with an ejection fraction of about 10% and was super sick. And this was a good treatment at the time it was done. But he used to say this. So just because one thing is done a certain way most of the time, we can think flexibly, and there may be better alternatives, in fact, if we think about it. I think another major takeaway that really affected my development was I had mentors that believed in me. And what I mean by that is that we had one aneurysm surgeon at UVA, predominantly Neil Cassell, who clipped all the aneurysms for my training, essentially. And he would go out of town. And when I was a fifth-year resident, he said when he went out of town, instead of leaving things for when he got back, he said that I should find an attending to staff the case. And so I had a patient who came in with an 11-millimeter ruptured aneurysm, and I had a surgeon who doesn't do really much open surgery. staffed the case, and I remember dissecting the aneurysm, getting ready to clip it, and I put the clip through the aneurysm dome, and there was tremendous bleeding. And the fact that Dr. Cassell had believed in me to take care of this situation, I had to just calm down and say, hey, I have to get this done or the patient's not going to get off the table. And I went through my steps exactly how I had been taught, and got the job done. But it was the fact that I had mentors who believed in me, maybe more than I believed in myself at the time, that was really critical in my development. I think the other thing was another example. This was when I was a fellow. Patient came in with subarachnoid hemorrhage and had this pica aneurysm that was located to the right side of the brainstem, although it was a left pica aneurysm, and really involved the pica vessel out of its base. And I remember Dr. Janes telling me that, that this doesn't probably look like it can be clipped directly, but maybe you can occlude it. And I talked about maybe a bypass, and he said, yeah, that's a great idea. So this is a video. I hadn't done an occipital pica bypass. I'd done plenty of STA, MCA bypasses. But this was a patient where the idea was to construct this bypass in the OR and then endovascularly occlude the aneurysm and parent vessel. And I'll just speed this along for illustrative purposes. But we constructed the bypass here and taken off the clip. And it was kind of hard because there was that atheroma in the parent pica. But we took the patient to the angio suite and then coiled it off and had the bypass fill retrograde. But this was an example where I had people believing in me to do this as an option, which was very helpful again in my development. And I think the other thing that I really learned that sticks with me today is that when things are going bad, it's super important to stay calm. I think because at least in the OR, the angio suite, you're kind of the leader of the team. So if you're panicking or swearing or, whatever, having a tantrum, then that gets the rest of the people around you uneasy, uncomfortable, and anxious. So Dr. Jane was a master at this, to stay calm under pressure when things are going bad. This was a patient who had this aneurysm that we were clipping, and I was assisting at the time, and you'll see this in a second. But I'm the one who's using that dissector, and we're trying to sharply take this vessel off. And you'll see in a second that I avulse the vessel at the neck. You'll see it in just a second here. Which is never good when you tear the aneurysm at the base. And so we end up putting cotton here, but in a very controlled fashion, going through the steps of proximal control and then ultimately securing the aneurysm. There's quite a bit of atheroma in the dome part of it. But getting it under control, and I see green with patency, but preserving the vessel. Just a stupid example of a mistake I made while we were dissecting it, but we're able to get control of the situation. I think the other thing that from residency was that I think principles that we learned at surgery could be applied to new situations. Not that this is special, but patient with brachial plexus injury, and this is doing an intercostal musculocutaneous nerve graft to help regain elbow flexion in this case. But this is applying microsurgical principles as well as anatomical principles to to new procedures, even though I didn't have a lot of exposure as a resident. And this was sort of another example of that same concept, using principles that you learn and applying them perhaps to novel situations. Patient who's very young, unfortunately, 32 years old, had multiple prior surgeries for giant cell tumor, had radiation, has this construct, has large recurrence here. There's no medical therapy from the oncology team's perspective. Patient is getting new weakness, has instrumentation in place, has a bunch of tumor extending into the paraspinal area, into the retroperitoneal area, etc. But using just sort of principles that we learn doing multi-level vertebrectomy and reconstruction and removing the tumor, removing the old hardware from the lateral procedure, old cage, doing re-resection, etc. And giving this patient a chance, but not, again, not that this is anything special, but the fact is that this was applying basic principles to a complex situation, as long as, you know, everybody understands the potential risks and understanding that there's no other options. So a couple of other quick summary points around lessons I've learned for surgery, and I still do this, but I rehearse surgical procedures, complex ones, especially in my head before I actually enter the room. So I've done the surgery in my head and visualized procedure, where things would go wrong, what I would do in those situations. And I try to get, you know, residents and fellows to do that as well. And another thing I learned early as a resident is very sobering, as you are learning to watch yourself on video, especially as an early resident, but it's a very effective tool, I think, for improving your efficiency and reflecting on areas that you could do better. And I also encourage that for residents and fellows. And then the other thing is that that was imparted on me is the simplest solution is often the best solution. So if you're taking, for example, an MCA aneurysm that could be clipped simply and you're doing double barrel bypass and proximal occlusion, well, that may work out well, but if there's a simpler solution that's safer, that is probably the best solution. And then I think, again, Dr. Jane was a master in this, but having flexibility in thinking. So you go in with an idea that you're going to do this in surgery, and you find out that it's not quite what you thought. So you have other plans in mind. I think the other way where this, an endovascular is a dramatic example of this, is as technology evolves, the best surgeons will also evolve. And maybe the best surgeons develop that technology, but certainly early adopters is important. And Dr. Jane, throughout his career, demonstrated that he would always try doing sort of the same thing in different ways, incrementally improving upon the way he was doing it before. And in all this, it's most important to keep the patient obviously as the highest priority, and to think of how you would want your family member to be treated in a similar situation. And another important thing, which I learned over and over again, is that it's important to stay humble and learn from every mistake, complication, and suboptimal or poor outcome. And I'm from Canada, and a hero of mine during medical school was Charlie Drake, who had trained Neil Cassell, my vascular mentor. But in the foreword of his book, it talks about, he published his experience on surgery for 1,767 vertebral basilar aneurysms. And the quote that he made is, "If only we could have back again many of those who were lost or badly hurt for a second chance in the operating room or endovascular suite or wherever we're doing our procedures with what we have learned." And I think that's so important. I think it's important to not only own any complication or poor outcome, but try and learn from that to ensure that it doesn't happen again, or to minimize the chance it will ever happen again. I think just to switch gears, and another thing that was really important during my time in Charlottesville was the concept of trying to improve the care of patients of tomorrow through research. And Dr. Jain was a scientist, neuroscientist. He was also a clinical researcher. He published in Science and so forth, but he emphasized the importance of research. So this is from one of the founders of Cleveland Clinic. We will have a continual policy of active investigation of disease, and this policy will be assured. That is to say, we're considering not only our duty to the patient of today, but no less our duty to the patient of tomorrow. And I think that we must aim to make discoveries that translate to improve the care of future patients. This was a patient who came in with this small subarachnoid hemorrhage here, and on initial study was found to have this PCOM aneurysm, which was coiled, but had a couple of other aneurysms, MCA aneurysm, anterior choroidal aneurysm, so had multiple aneurysms. And the patient was lost to follow-up, but came back 5 years later with this new subarachnoid hemorrhage. And statistically speaking, the aneurysm that ruptured would have been one of those that was clearly delineated on the other side. But in retrospect, there was a tiny bump at the carotid bifurcation on the right side, which turned into this aneurysm in 5 years. And you can see a pseudoaneurysm from on the dome there. And based on our literature, that shouldn't have been the thing that bled in the future or at the highest risk for bleeding. And it reminds us that we need to understand more about the biology of aneurysms. And I won't go into this too much, but what Dr. Jain had emphasized was, in some instances, laboratory research or translational research, and certainly clinical research is important. But we had spent a lot of time discussing laboratory research, and our lab investigates the biology of aneurysms, so why they form, why they grow, and why they rupture. And this was some work that we had presented, but basically we, and I won't go through this in a lot of detail, but had wanted to look at individual constituents in the blood vessel wall that could contribute to aneurysm formation and rupture using single cell RNA sequencing. And so we have pretty good models in mice. We can inject, and I'll show that in a second, but we can create aneurysms in mice, like shown here, that rupture. And this allows us to study basic mechanisms in an animal model that may apply to humans. And the procedure is done that we inject elastase, make them have high blood pressure. And then in this set of experiments, we can harvest the blood vessels themselves, create single cell suspensions, and then review things with single cell sequencing. And that is to see what changes are actually occurring in individual cells, like vessel wall constituents, like vascular smooth muscle cells. And using this single cell RNA sequence, we can look at aneurysms that formed, aneurysms that ruptured, and then some control group, sham in this case. But we can actually, in those blood vessel samples, look at individual cell types, vascular smooth muscle, macrophages, neutrophils, etc., to try and understand what is going on at a molecular level. And this was looking at vascular smooth muscle cells. We could divide them into 5 different clusters based upon their expression of certain genes. And we are interested in, because vascular smooth muscles are such an important part of the vessel wall, and we know that they're disrupted in brain aneurysms, and there's some element of dysregulation, and they change from a cell that normally is concerned with contraction and then become inflammatory, etc. We're interested in how those cells undergo changes, and I won't go through these data in detail, but this technique helps us look at that. And vascular smooth muscle cells change, and then they die, and then inflammatory cells, which are shown here, infiltrate into the vessel wall. And we know that inflammation is important in aneurysm formation. And we were interested in how vascular smooth muscle cell metabolism may change. So they rely more heavily on glycolysis as they're proliferating, and then eventually the cells die. But what we found is that vessel wall constituents become inflamed, degrade, and die, and that basic breakdown of metabolism with mitochondrial dysfunction may be critical in aneurysms forming and then rupturing. And the idea behind all this is to try and develop better therapies. So if we find a patient with an unruptured aneurysm, is there a medical treatment we can give that would reduce the risk of future rupture if treatment is more risky than typically observation? So those are some ongoing investigations in our laboratory and group members who have done the work, medical students, fellows, et cetera. And then to shift gears into sort of the final part, talking about education. This was one of Dr. Jane's mentors when he moved to Case Western, Frank Nelson, who was chairman there. He would say that the main reason we are here is not so much to advance our own career, but to help advance the careers of those who come after us. And Dr. Jane always emphasized the importance of the residency program and doing what was best for resident education. And if we look at resident development, it's so interesting because some residents, few residents may not make it through, and that's what this is supposed to denote. But in terms of surgical skills, some start off a little bit higher, some have a steep sort of trajectory where they become master very quickly, some more gradual. But there's all sorts of temporal evolution of how residents and fellows attain skills, and it's a very rewarding thing to see as residents and fellows attain mastery. But one of the critical issues that I know Dr. Jane and I used to discuss a lot was, how are we going to continue to train residents and fellows with all these regulations, compliance with, obviously we have to comply with guidelines, and there's a lot of discussion at ACGME that the duty hour restrictions are going to become more severe. But because I think neurosurgery requires such skill and how do we preserve the training that's required to get people to where they need to be to take care of patients? And I think that, in my view, and I think Dr. Jane's view, was that neurosurgery training is like training Navy SEALs or special forces. And we have to find a way to comply with guidelines, but preserve the elite nature of training, neurosurgery, or it could be orthopedic surgery, residents to be able to take care of patients at a continued high level. And, I think there'll be creative ways. Obviously, what SSF is doing, I think with simulation and other models, maximizing educational opportunities, I think is really important. And there'll be some novel techniques which we can apply. The other thing that Dr. Jane was a master of was mentoring. And this is William Mayo, but this is a great quote. He said, "As I've watched older men come down the ladder as down they must come, with younger men passing them as they must pass to go up, it so often has been an unhappy time for both. The older man is not able to see the necessity or perhaps the justice of his descent and resents slipping from the position he had held, instead of gently and peacefully helping this passing by assisting the younger man." But he goes on to say, "What a pleasure and comfort I have had from my hours with younger men. They still have their imagination, their vision, and the future is bright before them. Each day as I go through the hospital surrounded by younger men, they give me of their dreams and I give them of my experience, and I get the better of the exchange." And Dr. Jane was so masterful at this, bringing up, young residents, I think, fellows, junior attendings, even senior attendings. He was a master mentor and was so comfortable and confident in his own abilities that he was able to do this so effectively, but tremendous role model. I think the other thing that I learned a lot was around leadership. And there's different leadership models and all these things, all these components I think I was exposed to as a resident. And I was able to see master leadership, which I try to impart on, our trainees as well. I think that so as you go from learner to early, surgeon to master surgeon, et cetera, some will take on leadership roles. And whereas perhaps before leadership roles, you're interested in on how your career will advance, I think that in leadership, it becomes less about you and all about others. And this is Jack Welch, famous CEO of GE. But before you are a leader, success is all about growing yourself. When you become a leader, success is all about growing others. And again, Dr. Jane was a master at that. I think the other thing that has become so important now is, if you're not at the table, you're not going to have input, and decisions will be made, perhaps which you don't like, as a result. And so it's important to have a seat at the table. And I would argue that Dr. Jane's least favorite thing was attending meetings, but he had others to attend the meetings for him. But the concept was you need to have a seat at the table and an active role if you want to create influence and impact decisions. And then I think as we shift gear to looking at the future, this is Tim Cook. He was the Tulane commencement speaker a few years ago, but he said, the status quo simply won't last. Get to work on building something better. And perhaps related, as Jack Welch has said, change before you have to. And Dr. Jane had really emphasized this. Dave Saby, many know Dave well, but he talks about, first of all, thinking big and probably thinking bigger, and to try and look beyond the horizon as to, how you can shape the future. And I think we spend, and I'm very guilty of this, we spend so much time in the weeds taking care of patients every day, and that's super important, obviously. But it's also, I think, important to take a step back and think from a sort of a 40,000 foot elevation, and to sort of see the big picture. And I think pragmatism blended with contagious optimism for a bold future that is different is really important. And so we spend, and again, I'm really guilty of this, but a lot of time in the weeds here. And occasionally, we see the tree further on in the distance, and that's important to be able to oscillate between the two. But what Dave's talking about is trying to look beyond the horizon and to try and shape the future, look at sort of what's going on and try to anticipate what could have a really big impact for the future. And because Steve Jobs had said this, and obviously, I think Dr. Jane was somebody who thought he could make a lot of change in the world, and obviously did. But Steve Jobs said, because the people who are crazy enough to think they can change the world are the ones who do. And then to bring everything sort of full circle, my time as a resident, I absolutely loved residency training. I would, and this may be stupid, but I would go back and do it in a second. I had so much fun. And what Dr. Jane's thing was that, he heard residents complaining and, just it's a stressful time at times, but he would always emphasize, take a step back. And he talked about Lou Gehrig. And Lou Gehrig obviously died of ALS, but here is his quote when he learned that he was diagnosed with ALS. Fans, for the past 2 weeks, you have been reading about a bad break I got. Yet today, I consider myself the luckiest man on the face of the earth. I've been in ballparks for 17 years, and I've never received anything but kindness and encouragement from you fans. Look at these grand men. Which of you wouldn't consider it the highlight of his career just to associate with them for even one day? And so Dr. Jane would, not to compare neurosurgery residency to a fatal disease, but he would say it's great to be young and a neurosurgical resident because despite, sometimes we get lost in the moment that it's crazy and it's super hard work. It's so much fun. And he would bring this up. What a privilege. And he said he would love to be back in Young as a neurosurgical resident. So I'll stop there. I'd be happy to answer any questions that may arise. Thank you. Thank you very much for this opportunity.
Aaron, that was terrific. I really enjoyed that. It's a lot of kind of convergent evolution, sort of thinking about my own trajectory and some of the great people I was, mentored with and had the privilege to be with and learn from and get some of the lessons you got. And, a couple of things strike me. And one is the small little things earlier in your career that shifted just a little bit and you have no idea how much, a small change in your trajectory has impact over the years as that trajectory moves you away from the direction you were going into a more interesting place. And that's a beautiful quote at the end there from Lou Gehrig. And the part of that sticks with me is look at these grand men, and that the relationships and the ability of these great leaders to build those teams, to foster those relationships, to create that environment where you have that camaraderie and sense of corps d'esprit, really important.
Hey, Aaron,
Hey,
that was a
Rod.
great talk. I really, admire and, can relate to a lot of the, stories about Dr. Jane, obviously, since we trained together. How do you see, how do you see what Dr. Jane did for us in residency, affecting training and kind of, because so many things have happened, we've got work hours, we've got, I feel like there's just the amount of time that you can spend in the hospital and, how are you dealing with that now at Tulane and how do you feel that that's impacted, the training for residents when they graduate?
So I think that's a great question, Rod. I think that it's a big challenge that I don't think we have the exact answer to, but a couple of things come to mind. One is that we have to continue to select the very best, to recruit and attract the very best, because that people that are, congruent with our culture, I think that's really important. And then I think that we have to maintain elite standards that we can't, even with work hour restrictions, we can't accept less than the best. And then I think we have to get creative. I think that we have to implement, again, what SSF is doing, what perhaps simulation, 3D printing, virtual augmented reality, that's going to become part of it. I think that's really important as well. And then we have to find ways to, in the time we have available, make maximal impact. So making everything count. Maybe it's doing the surgery ahead of time. As you know, a lot of the surgery that, if you take open microsurgery, for instance, a lot of what we're seeing is more complicated. So I think it's a multifactorial approach that we don't have all the answers to. So I think that it's a work in progress. One other thing I wanted to say about residency, and I didn't have a chance to do this, was that Rod and I were co-residents. And one thing that to this day, Rod, I don't even know if I've told you this, but as a resident, you can kind of get down and beat up. And you are a guy that no matter what happened in residency, you are always positive, always upbeat, always energized. And it was contagious. So I'm a better person, a better I think, surgeon, as a result of your influence, because nothing got you down. It was very inspiring. So
He continues to spread that sunshine. I just want to say
Thanks,
it's really
Aaron.
it's a true fact.
Hey, so Aaron, this is Jens, and thank you so much for sharing your wisdoms and demonstrating again the transgenerational wisdoms and insights of Dr. Jane, who I had the great pleasure of being exposed to and benefiting as well. So I thought that was really phenomenal, from the literal microscopic realm going to the macrosphere across times and generations. The concrete question I have is, as we're getting an increasingly comprehensive data gathering ability, and fiscal constraints are rising more and more in the presence of a aging and more sick population. Where do you see quality of care criteria applied? Where do you see the fiscal balance of care as far as hospital systems are concerned under the pressure of an increasing aging and sick population, where the profit margins of the past are no longer there, and the mitzvah, the delivery for a service, becomes far more carefully scrutinized and criticized even by some?
yeah, that's a great question. So I think a couple of things. I think that we can have hopefully a proactive role in shaping that. I think that what we're going to have is and rely upon is high quality data as much as possible, and being able to bring data with reference to patient outcomes into our clinical care. Maybe some of it is, incorporating AI and et cetera into helping with efficiency and efficacy of care. But I think what it's going to come down to, and hopefully we can take a proactive role, is that there's going to have to be sort of initially some tough decisions made on standardization of care, consolidation of expensive rare resources, implants. There's going to be a lot of that, and we can take, again, a leadership role, or we can have it shoved down our throat. But I think that will be part of it. And then as a society, there may have to be some tough decisions made. For example, I know in New Zealand and other places, there's strict criteria on who actually can be treated. For example, if you're 85 years old and coming in with a bad subarachnoid hemorrhage, you may not receive treatment in some other countries. And there may have to be some element of that, but I think it's a multifaceted thing where there'll be standardization, incorporation of novel technologies, I think consolidation of rare and expensive resources, standardization, incorporation of data. I don't know. That's a tough question, Jens, but it's becoming more and more a problem that we have to address.
All right. We're coming up on time here. I want to just say again how much I appreciate that talk and how much it resonated with me. If you look in the chat, you'll see Tanya is sending her regards to you, somebody you'll remember from working with, I'm sure. And then I'm going to ask one of your mentees, someone who followed in your footsteps at UVA, to close us out here. Steve?
Thanks, Cameron. Thanks, Aaron. That was a great talk. Really enjoyed it, and brought back some memories, some traumatic, some less traumatic. So it's been great having you. I did have one question just to finish off with regards to the kind of cultural change we've seen with residency training. You talked about Saturday conference and Sunday school, and the kind of cultural change we have now with integrating neurosurgery into lifestyle, and questioning of residents' commitment versus having a healthy life that involves not just being in the hospital. I just wanted to see what your take was on how you balance the kind of Navy SEAL mentality with the having a balanced life, working hours where maybe your working hours are ending for the day, but you're in the middle of a case, and you're obligated by the GME to leave the surgeon to finish the case by themselves in those sort of awkward situations.
Mm-hmm. So that's a good question, Steve. I think one of the things we have to do is in the time anyone is engaged at work, we have to have, again, the highest standards and be all in. I think my view of the world has changed as well, because I think to be at your best, you have to keep your own wellness in mind, which is a stark change. I thought you could be, 24/7, 365, but I think that actually promoting wellness and having interests outside and paying attention to that is important. So when you are at work, you're at your best. I think that maintaining a culture where, the Navy SEALs culture during the time we have allotted is important, and we can't let that go. But I think that because I deal with other residency programs like, maybe medicine specialties where the attitude has totally changed, we have to select people who, sort of fit into the culture of neurosurgery. I think we have to respect boundaries. I think with respect to in the middle of surgery, I think we have to have some common sense. And fortunately, people will continue on in that surgery if it's best for the patient, and there will be still some exceptions. But it is a great point. I mean, it's difficult, but we have to find a way to preserve it.
Great. Well, maybe on that note, I know we're at time. Great seeing you again. I know you taught me a lot with both neurosurgery, open neurosurgery and endovascular surgery, and passing on the lessons that we learned from Dr. Jane. And we really enjoyed having you here today.
Thank you very much.
Thanks, Aaron. It's great having you.
Great
Take care.
talk,
Have a
Aaron.
great day.
Bye.
Bye-bye now.